Well, hey everybody, it's Dr. Chris Pittman, Vein 911 Vein Treatment Centers. We're going to do a live foam sclerotherapy on a willing victim, patient who's an amazing doc, in amazing shape. And I'm here with Miss Ava.
Hello, I'm Ava. I'm one of the medical assistants here.
And she's a barista, for those who followed me in my lectures. So we lecture internationally and nationally on foam sclerotherapy. We think we perfected foam. We put out many tips and tricks, but some folks are about 80 to 90% of the way there. And this is for Dr. Luke Matar out in Perth, Australia, where it's probably, middle of the night right now. But anyways, we're going to do this on a regular basis and show everybody how we do foam sclerotherapy. So this patient is in amazing shape, but has some genetic vein disease. You can't see, but he's a 4C classification. He's got frank chronophthalmic tatica. He's already undergone thermal ablation, and you should be able to see the ultrasound here. So I'm up in the groin area. You see common femoral vein. We've already ablated his accessory saphenous vein, which bifurcates right here. Here's his GSV. He's got a posterior accessory coming over here that frankly, probably we can go ahead and get. So I'm going to bend your knee just a little bit more, and we're going to fumigate every vein we can see here. So I'm going to have to twist my head around just because of the way we are today. So apologize, right's not my best side, but that's what we're going to have to do, at least for today. Actually, this posterior accessory, not too bad, so I'm going to leave that alone. You can see that there's a little bit of sponginess in this great saphenous vein in the upper thigh. And when I go long, I can see some intact intima. You can see these white lines here. So I'm going to go ahead and reinforce that with some foam. Talked about this in some lectures. If you inject foam in a thermally ablated vein, you will be shocked at the fact that these veins are not really completely closed. And so I'm going to reinforce this. We not uncommonly do inject foam into thermally ablated veins. So we're in the lumen there. We're going to inject, and you're going to see a little sludgy there. You see some foam. I'm going a little higher. See, we're moving some sludge out of the way. So I'm just reinforcing this GSV is what I would call this. Even with thermal ablation, you do not close that vein 100% of the time, every time. I don't care how good a thermal ablationist you are. And obviously the ultimate, I'm up in the junction now. You can see the foam's gone all the way up there, which is great. But no matter how good a thermal ablationist you are going to have segments, sometimes even long segments, that aren't going to close. And in general, the only way you're going to be able to deal with those is with foam sclerotherapy. So foam sclerotherapy, of course, is the ultimate safety net. And so I'm going to go ahead and reinforce this as well. We've already treated his other leg. He was a very target-rich environment. He's got a lot of varicose veins. And we have him wearing double compression. So we routinely have people wear 20 to 30 millimeter of mercury compression hose. You can see we're reinforcing this GSV here. Again, nothing particularly challenging here, but when people have a high venous burden and bulging veins, we're going to have them wear two hoses, or two 20 to 30 millimeter mercury hose at the same time. Most people can tolerate that. Over here we can see here's his GSV, but he's got some tributary veins that are already closed off. But down here is where he's just got a lot of stuff going on. So you can see these are kind of compressing. And so Ava's going to give me a high caliber, lots of foam here. We don't want to under foam. Most practitioners put too little foam in their patients because they're unnecessarily afraid or intimidated by it, thinking they're going to clot off deep veins. That is something, as we continue on our live foam sclerotherapy series, we will get people over. So this is about 2 cc's of 1% polydocanol foam, 1 to 4 with room air. And I'm injecting this. And of course, the sine qua non of foam sclerotherapy effectiveness is complete venospasm. And you can see that right here. Those black pipes have turned into white lines. And for the lay people who are watching, that's how easy it is to get rid of bad veins. There's no role for surgery in vein care. Yeah, I'm going to irritate some surgeons out there. That's okay. There's no role for surgery in vein care, and friends don't let friends get vein surgery. How are we doing? All right, awesome. So you can see that densely packed snake den of varicose veins is now a bunch of little white dots. So we have had excellent effectiveness with this foam sclerotherapy in this area. Above the knee, you can pretty much inject 1, 2, 3, 4 cc's of foam with impunity for reasons I won't get into. But for those who are part of foam sclerotherapy experts on LinkedIn, or you can go on LinkedIn, ask to join foam sclerotherapy experts. I go into the reasons why you can inject pretty much with impunity above the knee. Above the knee, I'll take more here in a moment, with foam sclerotherapy. So again, this is a GSV, kind of going over the joint. Again, the intima is white. It's this white line. It's a little too intact for me. And so I'm going to hit this again, what we call in this office, just reinforcing this vein with some foam. So it might close on its own, it might not. Anyways, there we're in. We're going to inject. And once again, you're going to see foam moving throughout the previously thermally ablated GSV. Below the knee, however, especially beginners doing foam sclerotherapy, you want to be very careful with the volume that you inject. Now, if we look right here, I'm looking a little deeper. You can see that there's a little bit of foam in the deep veins. Unfortunately, I don't have. Well, actually, I do. Do I have a pointer? I don't know. Do I have a pointer? I think I can have a pointer. So if we look right there, there's a little bit of foam on the top, on the superior aspect of this perineal vein, but it's not doing anything. There's no spasm. It's just not enough foam to do anything to that deep vein. So here's basically we're getting into the popliteal artery, popliteal vein. Anyways, there's just no reason to be afraid of a little bit of foam going into the deep system. We go into the details on that in foam sclerotherapy experts. So we're going to go a little more shallow here. And he's already had some varithena or some proprietary foam in the great saphenous vein between the knee and the ankle. And so that's why his great saphenous vein here is fairly occluded. Probably started that injection here. You can see this is his perforating vein, which to a lot of lay people sounds abnormal. But this is a vein right here that I'm going to go ahead and freeze this. Now I'm doing full-on lecture. I'm doing more than just foam here. But you can see between here and here, this large vein goes from the great saphenous vein into the muscle. This is the bottom of the basement. We often say that vein disease is leaking the attic flood in the basement, what we see in fields between the knee and the foot. but the problem starts way up in the ankle. So we always want to block veins up above the knee first, and then do below the knee at the end. We don't want to bail water in the basement before we fix the leak in the attic. So I'm going to come, again, you can see a little bit of foam in that deep vein, no big deal there. So I think what I'm going to do, and then we're going to wind up for this inaugural live foam case. I'm going to put a little more foam. I can see a number of, and he's way too good looking for this blue-purple stuff in his feet down here and ankles. And so we're going to help him with that by injecting into some of this mess down here. He's just got a mess of varicose veins. We routinely really inject anywhere, feet, ankles, toes if we have to. There's no need to be afraid of foam sclerotherapy in the ankles or feet if you know what you're doing, and it's not that difficult for us to show you over time how to get this done. So I'm just looking for the most ideal spot here. Go ahead and straighten you out just a little bit, and I think we're going to go right here. Okay, so this is right, hopefully y'all can see that, right above the level of the medial malleolus. And I'm going to optimize my image a little bit there. There we go. All right. And it's actually a lot harder to hit veins, pinch, that are right under the skin with ultrasound. So what I did here is I actually bent this needle, which I don't recommend you do to begin, because it makes the injection a bit more complicated, but we can talk about that another time. And so you can see my needle is in there, and we're starting to inject. And so that used to be a black pipe. What you see down there, those big black pipes are in his deep venous system in his muscles. And this guy is athletic, so he's got really big veins to accommodate all that blood flow. But you can see that mess of veins that was right under the skin, between the skin and the muscle, for those out there who do foam sclerotherapy, has gone into complete spasm. And you can see, wow, there's just nothing in that deep system. I've said the best way to really understand the hemodynamics of foam sclerotherapy is to do or watch a lower extremity venogram, which unfortunately, I guess, is ancient stuff, because superficial veins, unlike what many are taught, do not preferentially flow into the deep system. And this right here is, again, proof of that. So how you doing up there, Doc?
Doing great.
Awesome. So anyway, I think we're going to leave it at that. Appreciate everybody tuning in, and we'll see you next time.